Malignant lymphomas, non-Hodgkin's lymphoma and Hodgkin's lymphoma. Classification. The malignant lymphomas are a broad group of diseases with a variety of clinical presentations and outcomes. Classification systems for the lymphomas are often confusing and have changed substantially over the years. The basis of classification systems is to take into account a number of properties of the tumor. These include morphology, immunophenotype, genotype, normal cell counterpart and clinical features, site of origin, aggressiveness, and prognosis. The current World Health Organization, WHO, classification is shown in Table 17. Lymphomas can also broadly be described as high-grade or low-grade, which can be a guide to treatment. Hodgkin's lymphoma, HL, represents a group of diseases with distinct histological features, including a pathognomonic cell, the Reed-Sternberg cell, although many of the clinical features overlap with other lymphomas. Etiology and Pathophysiology. Non-Hodgkin's lymphoma. In the large majority of cases the cause is not identified, although a number of factors are known to play a role in their development. Inherited disorders affecting DNA damage or repair, e.g. Fanconi's syndrome and ataxia-telangiectasia. Infective agents, bacterial, e.g. Helicobacter pylori and gastric lymphoma, and viral e.g. Epstein-Barr virus, EBV, and human T-cell leukemia and lymphoma virus 1. Immunodeficiency or dysregulation, e.g. inherited syndromes, immunosuppressive therapy, HIV infection, and autoimmune disorders. Ionizing radiation. Carcinogenic chemicals. Hodgkin's lymphoma. Certain factors may play a role. Genetic and occupational factors, e.g. familial aggregations, human leukocyte associations, benzene and nitrous oxide. EBV. Epidemiology. Non-Hodgkin's lymphoma. In the UK the annual incidence is 11 per 100,000. It is slightly more common in males and increases with age. It has become much more common since the 1970s. Geographical variation in certain subtypes is marked. Hodgkin's lymphoma. The annual incidence in the UK is 3 per 100,000 males and 1.8 per 100,000 females. There is a peak incidence in the third decade. In those aged 15-34 years old, this is the second most common tumor in men and the fourth most common in women. Clinical presentation. Lymphomas present in a number of different ways. Lymphadenopathy. In early stage HL this is most likely to be localized above the diaphragm. Non-Hodgkin's lymphoma, NHL, is more likely to present with generalized lymphadenopathy. The lymph nodes are classically painless, non-tender, asymmetrical, and rubbery. Hepatosplenomegaly, more common in NHL. Mediastinal involvement, may occur in both. Constitutional B symptoms, fever, may be cyclical in HL and Pell-Epstein fever, night sweats and weight loss, 10% of body weight in 6 months. HL may also present with pruritus or alcohol-induced pain. Bone marrow failure, features of anemia, thrombocytopenia, and neutropenia. Oropharyngeal involvement, in NHL this may cause noisy breathing or a sore throat. Skin manifestations include nonspecific rashes, infiltration, and mycosis fungoides, Fig. 28. Other organs, much more frequent in NHL. Affected areas include gastrointestinal tract, brain, testis, and thyroid. Investigations. Histopathological examination of the affected nodes and tissues will help to define the subtype of disease. Normochromic, normocytic anemia, hemolytic anemia may complicate NHL. Leukocytosis, abnormal lymphocytes on the blood film in NHL, Fig 29, eosinophilia and neutrophilia in HL. Bone marrow aspirate and trephine. In HL the aspirate is often reactive, although not involved by disease. Immunophenotyping of blood or bone marrow samples can show the clonality and characteristics of the malignant cells. Lymphopenia. In HL, consider coexisting HIV infection. Raised erythrocyte sedimentation rate and lactate dehydrogenase. Paraprotein, NHL. Imaging, CT, MRI, or PET, see below, scans of the pelvis, abdomen, and chest. Cytogenetics, a number of subtypes are defined by specific chromosomal translocations, e.g. T, 11, 14, in MCL. This is now considered a routine investigation. Tests such as gene microarrays are becoming increasingly important in this group of diseases, but are not yet available or validated for routine use. NB. PET scan using fluorodeoxyglucose, performed with or without a CT scan, is used in patients with lymphoma for staging, response assessment, and prediction of relapse. It is currently a very expensive technique and not readily available in all areas. Staging. The updated Ann Arbor classification is shown in Table 18. Treatment. Non-Hodgkin's lymphoma. In general, the management of this diverse group of diseases is performed with chemotherapy, and depends on whether it is predominantly of an aggressive or indolent nature. The use of both autologous and allogeneic transplantation, usually as part of the management for relapsed disease, has increased in recent years due to the increased safety of these procedures and the good outcomes seen. Low-grade disease, which may be asymptomatic and have no significant effect on quality of life in some cases, often requires no treatment or only intermittent treatment with oral chemotherapy. This disease is not curable by chemotherapy, or an autograft, alone. In aggressive, high-grade disease, combination chemotherapy is usually indicated. The gold standard treatment in most of these patients will be R-CHOP chemotherapy. This is a cyclical regimen of chemotherapeutic drugs, cyclophosphamide, vincristine, daunorubicin, and prednisolone, with the addition of the anti-CD20 monoclonal antibody rituximab. Up to 50% of patients can be cured. Stem cell transplantation is often recommended at relapse. Those patients with a large disease bulk are at risk of developing tumor lysis syndrome and appropriate preventative measures should be taken. Newer treatment strategies are constantly being evaluated. These include newer monoclonal antibodies, anti-angiogenesis agents, e.g. thalidomide, and vaccines. Hodgkin's lymphoma. Radiotherapy is usually used in conjunction with shortened combination chemotherapy in stage I and IIA disease. The use of combination chemotherapy in instances of more advanced disease has been very successful, with the number of regimens reported to induce complete remission in 60–90% of patients. Again, stem cell transplantation is usually reserved for relapse. NB. Because many patients with malignant lymphomas are young, it is essential to discuss the potential loss of fertility that may result as a side effect of intensive chemotherapy. The patient should be offered the opportunity to cryopreserve semen or ovarian tissue prior to commencing treatment. Complications, particularly of Hodgkin's lymphoma. In view of the success of the above-mentioned treatment strategies, there are increasing numbers of long-term survivors who may experience a range of delayed side effects. Second, malignancies, infections, endocrine abnormalities, cardiac and pulmonary toxicity, psychosocial problems,